Thank you very much, Professor Kai Zakharovsky, for a very good analysis of the current data that is held in the aprotinin registry. I'd now like to thank all the speakers and open up the session for question and answers. We have a little bit of time available that we can discuss, and I would like to invite my co-speakers, Professor Zakharovsky and Professor X, to join me on the floor and take the questions. Now we'll start with some basic, simple questions that have been directed, and then we'll sort of work our way through, if you like. The first question that arrived was actually directed to me, and it was asking about my personal threshold for blood transfusion in simple CABG patients. And to answer that, I look at two aspects of things. I look at the patient physiology from the patient's background status, their preoperative status, comorbidities, and other things. I look at the rate of blood loss that's also happening as well, and I look at the hemoglobin level as well. So it's not just a simple, yes, do you treat if the hemoglobin is less than 8? It's whether the blood loss is occurring at a rate faster than that, and whether or not the patient is maybe an octogenarian, 8 years or above, and what levels they will tolerate. But for fit, young cabbage patients who've got nothing else going on, my personal threshold is less than 8. The next question we have is directed to Professor X, and that is the incident of exposure to fibrin glue is almost impossible to detect, isn't it? So what do we do in that case when we are using or planning to use aprotinin?
Yeah, it depends on which kind of surgery had been performed. So I don't think that for example, for a gynecological operation that anybody would have had used free sealant with aprotinin. So, and I think that it has never been investigated, but it should follow the same. So after 6 months, the incidence of anaphylaxis to aprotinin in this fibrin sealant should be very, very low. And again, this should also be detected by the test dose. So I think if there is a relevant problem, then you should detect this with the test dose.
Okay, great. Kai, do you have any comments on that, or should we move to the next?
Please move to the next. I have no more comments.
Okay, so we have another question for Prof. Rex. Aprotinin, in the data that you presented, was used in CABG and valve surgery in 148 patients versus 58 patients that you used it in thoracic aortic surgery in Leuven, which is in contrast to the practice in the UK and Ireland. Any idea why that was the case, or how you might choose to explain that? The differences between the countries?
I think this is not really a difference between the countries. The reason is, in my opinion, that we perform much less surgeries on the thoracic aorta than that we do combined surgeries on the valves and on cabbage. So, I mean, in this time period, we consecutively included all patients having these indications that I displayed in one of my slides, and yeah, the surgeries on the thoracic aorta are just less frequently performed than these other complex procedures.
Okay, the next question is relates to the let me just find it. The registry itself and the completion of the registry within the UK. Now, as Prof. Zakharovsky showed in his last slide, the data entry set is actually now closed. So in response to Dr. Hare's question, you can use aprotinin in the UK without the completion of the registry data now in the UK. The next question we've been presented with is open to both, I guess. When we're talking about high doses of tranexamic acid, what doses are we talking about? Are we talking about greater than 6 grams a day, or any specific dose that you want to address?
This is a very strange thing about tranexamic acid, because if you ask 90 cardiac anesthetists how much tranexamic acid do you use, you will receive 120 answers. So the dose response relationship for tranexamic acid is very ill-defined. There is no international consensus on the most effective dose. So, but in most studies, or the biggest and methodologically best study is a study by Paul Miles on tranexamic acid in coronary artery bypass surgery, published in the New England Journal. They started with a so-called high dose. This was 100 milligrams per kilogram. And after they observed a lot of seizures in this, or not a lot of, a considerable number of seizures in the tranexamic acid group, they reduced the dose to 50 milligrams per kilogram. So if we would follow this study, then a high dose would be 100 milligrams per kilogram, and a cumulative dose of 100 milligrams per kilogram, and a lower dose of 50 milligrams per kilogram.
Sure. Any views on that, Kai? I agree with that.
Nothing to add. Is absolutely correct. I read the question here right at the end, so I can help you a little bit with moderating. Why have there been no randomized control trial comparing aprotinin with tranexamic acid? And that is a really interesting question, because we were thinking about this, but it's very simple to say. No one will finance it. So the only way we could have a trial like this would be if we do an IIT, so investigator initial trial. But no pharma, no one will finance this trial. And I think also it's a good question, but I think you cannot compare aprotinin with tranexamic acid in that way. And at the moment, as we know, aprotinin has a special indication. It's only for eye cabbage, where you have a high risk of bleeding, nothing else. And the UK has been used for all cases where we expect a major bleeding. So you can't even do a European trial, I think. So.
No, it's interesting, isn't it, that the data is only 25% of the patients have had actually used in the indication that it should be used as, and
only in Austria and Germany they use it. And
stick to the rules, the speed limit.
Yes. We don't like speed limits, but at least for aprotinin we do it.
So another question has come from Professor Peter Alston, saying that aprotinin is very expensive, whilst tranexamic acid is very cheap. Does anybody think about the economics of this in the decision to use these drugs? What's your views on those?
Well, I can answer this. So far, there has not been really any research done on the real economics. What aprotinin is might be superior in comparison to tranexamic acid. But what has been done some years ago, the use of point-of-care methods and algorithms in cardiac surgery related to bleeding. And there was a clear benefit in cost, in outcome, and death if clinicians would have followed algorithm and using point-of-care methods. And I know in this trial aprotinin was also being used, but only part of an algorithm. This wasn't the drug which has been investigated in comparison to everything else. It was just part of the whole game. But it would be, again, interesting research.
Yeah. So another question similar to that is based on what's the full cost of aprotinin in UK and Europe. I know that the cost of the vials varies from country to country. And I guess that's a difficult question to answer, because the availability of the drugs will be, although constant across Europe, the price per bottle will be different. So it's difficult to answer that. But for 2 million units as a loading dose and 2 million units into the pump, the full Hammersmith regimen, and 500,000 dose per hour as an infusion, what's the approximate cost in Germany? Any idea? Likewise, Prof. Rex, any idea in Leuven?
Yeah, so we... in Belgium, it's around, I think, 70 to 80 euros per ampule. So if we use a half Hammersmith dose, then we approximately use 6 ampules, so 3 million key IEs of aprotinin, then we end up around 400 to 500 euros. So. And this may also answer the question of Pete Alston. If we could save only one packet sell with this investment, I think we are at the point of it's a break even. So, but this is difficult. This is just guessing. So I agree with Professor Zacharowski. For this, you need a serious pharmacoeconomical analysis, which is not so easy to perform. This is a PhD on its own.
Yes, no, that's absolutely right. Because remember, the corollary of that is that you're reducing transfusion of blood products and red cells, and there's a cost saving to be derived from that. So it's not just the actual cost of using the drug itself. Another question has come up is that do any of us use aprotinin for deep hypothermic circulatory arrest? And if so, how do we manage anticoagulation on hypothermia? And related to that, there's another question: do you use it in neonates as well? So I guess that will go to Prof. Rex to start with, and then Prof. Zacharowski next.
For DHCA, we use it routinely because I think these patients have a big benefit from it, a large benefit, because they are known to have, or they are prone to coagulation abnormalities due to the severe hypothermia. And we manage anticoagulation as in every other patient. So targeting, and we use a kaolin ACT. So we target an ACT of somewhere higher than 480, 500. And this is done routinely. In neonates, we don't use it because I just summarized some data and submitted them for publication over the use of aprotinin in children. It's very difficult to find there a consistent dosing regimen. And I think in children, or in neonates at least, hyperfibrinolysis is not the major issue. The major issue in pediatric cardiac surgery is the dilution of coagulation factor. So these children suffer extremely from dilution coagulopathy. If you imagine that you have to prime, even if with the miniaturized CPB circuits, you have priming volumes of around 120 to 150 cc, and in a neonate of 3 kilograms, you have 300 mLs blood volume. So you dilute the blood volume of the neonate by 50% with your CPB prime. So you have a lot of coagulation, dilution coagulopathy. So I don't know whether aprotinin is really the magic solution to their bleeding problems. So we do not use it there, but the data are interesting. And I saw by the presentation of Kai Zacharowski showing that a lot of data in the NIPA registry are related to the pediatric use. So I would be very interested to see a sub-analysis of these data.
I can just add, Aamer, that obviously before the suspension of aprotinin in Germany, it has been used in all certain types of surgery. But since the new introduction, basically it was 100% of all the cases were ICABG. So the new data, obviously, I cannot comment on your question.
Sure. I mean, in the UK, certainly our practice is very similar to what Stefan's described, in the sense that for deep hypothermic circulatory arrest with patients at high risk for bleeding, that would be an indication for us to consider using it. Although it is what we've been discussing is off-label use. You've seen that 75% of the usage is in fact used in redo surgeries or complex aortic surgeries. One or two more questions have come up. The adverse outcome that we associated with seizure activity with tranexamic acids, is that due to the associated value of plasma concentration of tranexamic acid, or is it because these patients were susceptible to having seizures because of their open hearts? I think this is referring to Paul Miles's study, where they found a subset of those patients had a higher risk of seizures only on the open heart procedures rather than the closed heart procedures. Any comments on that?
I think it's an inherent, or it's an inherent side effect of tranexamic acids. In some animal data, it has been shown that tranexamic acid interferes with transmitters in the central nervous system, that is with glycine and also with the GABA system. So it's I've seen it I think now 2 times in fast track patients that we did. They had a very uncomplicated surgery, aortic valve, minimally invasive surgery, certainly no air in the ventricles, and on the PACU, even after extubation, they started to have a seizure, and then all the follow-up was done by the neurologist, MRI and things like this. Nothing could be found. So I think it's really an adverse event or a side effect of tranexamic acid, which can be explained by the interaction with these 2 inhibitory transmitter systems in the brain.
Sure. Prof. Zakharovsky, any comment on that at all?
No, because I never would correct Prof. Rex.
Very good. Okay, so we've got 4 more minutes left for questions. We had another question submitted to us, which was that does anybody do von Willebrand factor dosing in patients who've got congenital heart disease that are at higher risk of bleeding? So not directly related to what we're talking about, but it's something that's come up. No, we don't either. And another question that was submitted to us is, what about the cost effectiveness of using prothrombin complex concentrates to control bleeding versus the use of aprotinin? Again, this is a pharmacoeconomic question. Comments?
Well, I can comment or add what I said before. We published some years ago exactly this research question, not a comparison of factor 2, 7, 9, and 10 in comparison to aprotinin, but part of an algorithm. And the point is very simple. If you start early testing with point-of-care methods and use an algorithm, you definitely save money and you have a better outcome of your patients. So the answer is a clear yes, but it never has been tested in comparison to aprotinin. And I think one drug on its own never does the job anyway, because a patient can have lots of problems. We heard dilution. There could be, there's so many reasons. So you have to treat what is basically not in order, and then I think you can change the outcome, and it will be cheaper.
Yes, no, I agree. It's a specific factor issue that we're trying to treat there rather than a generalized protease inhibition from aprotinin. I think we're going to wrap this up now because time is getting on. If there are any more questions, feel free to submit them and we will try to answer them and post them on the EACTA website once things are done. So just to close the session, I want to just say, first of all, thank you for asking us to speak, and thank you to the great speakers, Prof. Zakharovsky and Prof. Rex, and for Professor Mohamed R. Tahan for organizing this. The take-home message really here is that aprotinin, which is received the Class 1A antifibrinolytic recommendation under the EACTA EACTS guidelines, is been shown to be safe in the NAPA registry, and in spite of the controversial debate that has been raging nearly now for over 12-13 years about should we or should we not use it, and does it or does it not cause renal dysfunction, I think you can see that in terms of clinical practice, nearly 3/4 of the people who use it and those who have it available in their centers use it in a slightly off-label basis. But the main approach that we should be taking for isolated CABG patients is that we should not look at just the complexity of the surgery, but also the nature of the patients themselves. Are the patients at high risk of bleeding, or are they at low risk of bleeding? That should determine whether or not we choose an antifibrinolytic agent of choice. But the main thing to take from this is that aprotinin is safe and it should be considered for those specific cases. Now, it gives me great pleasure finally to introduce the president of the EACTA, to invite him to close up the session. Professor Fabio is works in the Department of Anesthesia and Critical Care in Pisa, and he's the head of the Department of Critical Care in Pisa in Italy. He's the current president of the EACTA, and I would like to invite him to say a few words and to close up the session. Thank you very much indeed.
Thank you very much, Aamer, and good evening, everybody. It's really a pleasure for me to join now the webinar and the audience at the end of this fantastic webinar. I just would like to thank the chair and the speakers for the excellent scientific program, and also the educational committee of EACTA IC for their work in organizing these scientific events. Well, of course, I also need to thank the organization, which is AIM, for supporting the webinar. Now, as you all know, the webinar, as we usually do at the EACTA IC, is accredited for the UMs to provide CM credit points. And also, I really need to say that the webinar received an unrestricted educational grant from Nordic Pharma, and we are very grateful for that. Before saying goodbye and stay well, as we usually do, I really invite you to join us for our next webinar, which will be very soon on May 30. And the next EACTA IC webinar will be on perioperative challenges for heart transplantation. So I really look forward to meeting you all for this next webinar. I thank you again for your support and your contribution, and I wish you all a very nice evening, and stay healthy and stay safe. Thank you so much.